Hi everyone. Let's join us. We are here in the second edition of the best PSM article. This year we are going to discuss the article published by Alvaro Arjona, and it was chosen the best article of 2023. We are going to have some minutes to people to enter. And meanwhile, I will present myself and my co-chair. My name is Artur Reis. I am from Brazil, and I am an ESSO certificated PSM surgeon here in Brazil. I coordinate a program of PSM in the hospital in my city, São José dos Campos. It's a city near São Paulo, Brazil. And I am member of the Education and Training Committee on PSM since 2022. As my co-chair in this webinar is Olivia Esgarbura, that is a surgical oncologist at Cancer Institute of Montpellier, France, and she's member of the board of Rede and French Society of Surgical Oncology. She's also co-chair of the ESSPP and PSOG Clinical Trial Task Force for PSM, a trainer of ESSO, and a new member of the Education and Training Committee on PSM. Welcome, Olivia.
Thank you, Artur, for this kind presentation. And it is my pleasure now to introduce you our tonight's guest, who is Alvaro Arjona. He's not only a very good friend, but also a surgeon passionate about pseudomyxoma peritonei and colorectal peritoneal metastasis that has been working hard in both fields. He has published recently his randomized clinical trial in JAMA, and we'll hear more about it tonight. And he is the coordinator of the research in peritoneal oncology surgery group in Spain and a surgeon in University Hospital Reina, Sofía in Córdoba, Spain. Welcome, Artur. Alvaro.
Hi, hello. I'm very happy. Olivia and Artur, thanks for your invitation. I think to select our paper for the best paper in 2023. I think that it is too much, but thanks for this prize. Okay.
We are looking forward to hear everybody introduce themselves, if you can, or some of you in the chat, as Maria already invited you to.
Okay. Okay, the chat is open. We now are going to hear the Alvaro's presentation, and after we are going to run a poll for everybody to answer, and after we are going to open for questions for Alvaro, and we are going to have a brief discuss. Alvaro, you are free to start anytime you want.
Okay, I'm going to start to as we planned it to talk about what is the origin of the Hyperthermic. Hyperthermic was started in 2015, and it was thanks to the publication of some pioneers on the peritoneal surface malignancy, has San Martino, for example. The study about the use of the prophylactic in T4 colon cancer. I was impressed with this paper, with this result, but there was no randomized trial. I think that we need evidence that has a randomized trial to combine our colleague oncologists for the use of hyper, and we started this adventure of the Hyperthermic years ago. The most problem that we have with the Hyperthermic was the font, to find font to support this trial. at the beginning, we accept some donation for the industry. It was a donation, but after that, after starting the trial with a very low cost trial, we got some public grant for the trial, and then we can continue with this trial till today. No, today we have the result of this trial. It was a very nice story, and also I have the collaboration of all of the Spanish group of the peritoneal surface malignancies. It was a very good base to do this trial, because all the group was very happy to collaborate on this trial. Okay, very quickly, I'm going to share my screen. I'm going to talk about the trial. Do you see my screen?
Yes, we can see it.
Okay, do you see it, the presentation? Yeah.
Yeah.
Okay. I will start with that. Okay, but again, thanks to select our paper of the Hyperthermic 4 trial for the best peritoneal surface malignancies paper in 2023. We are going. I have no discussion, of course, but we are going to talk about how to prevent the peritoneal carcinomatosis in high-risk colon cancer. Yeah? All our grandma say that it is better to prevent than cure. It is very classical phrase, and we are going to prevent the peritoneal carcinomatosis. We know that as you see in the image on the screen, the PT4 colon cancer is recognized as a high-risk condition to develop the metachronous peritoneal carcinomatosis. Several strategies are under research today in order to prevent this recurrence for this specific subgroup of the patient. I'm going to summarize the different strategies to prevent the recurrence of the patient. For today, we have the adjuvant therapy. Adjuvant therapy is based in oxaliplatin fluorouracil after surgery. It is based on the result of the Mosaic trial. It is based on Sakura trial. It is based in Quasar study. It is old study, but well, this study show that some benefit for the T4 colon cancer with the use of fluorouracil, not oxaliplatin was used, but all of them was the germing for this use of the adjuvant therapy on this patient. But we pass to the new strategy for the T4 colon cancer. That is a neoadjuvant therapy. That is changing in the paradigm for treat this patient. Either we are going to use the chemotherapy, systemic chemotherapy before the surgery for this patient. But this recently have been published this nice paper in British Journal of Surgery about the benefit to prevent the recurrence with the neoadjuvant therapy in stage 2 high risk and stage 3. This meta-analysis say that it is, yes, the benefit, we have benefit for the neoadjuvant therapy, but this meta-analysis is based overall in the Foxtrot trial. But we are going to talk about Foxtrot trial later. We have another trial. This is a stage 2 phase 2 trial. This is the PRODIGE 2022 that they did not achieve the statistically benefit for the use of FOXP4 in locally advanced colon cancer. But on this trial, you can see that the clinical T4 was only 6% of the population included on this trial. This percentage, it is very important along my thought. This is the 33% of the patients were estimated to be overtreated on this trial. Another trial was presented in 2022 was the optical trial. This is the patient were randomized for the locally advanced in clinical T3 high risk with more than 5 millimeters of the penetration on the pericollic fat, and clinical T4 in the imaging test. We have not the paper for the optical trial. We have the ASCO presentation, but in the preliminary result with a follow-up, median follow-up, the 32-month, they did not find different on the disease-free survival between two groups. It was the primary endpoint for that. But this year had been published the Foxtrot trial, and the Foxtrot trial achieved the objective to find the benefit of the neoadjuvant chemo for this population of the patient, the population of the high-risk patient. You can see here that the use of the FOLFOX before the surgery improved the 2-year recurrence rate on this patient. On this trial, this is a very nice trial. I invite you to read deeply this trial and the supplementary material. It is very nice. And also, as I referred before, the estimated overtreated patient on this trial was 24% of the population. Now we go to the HYPEC strategy, and the HYPEC strategy was very controversial on the high-risk patient. The prophylactic trial, all of you know about the prophylactic trial. It was in summarized, it was patient with high risk to develop the metachronous peritoneal carcinomatosis. This patient was operated, this patient received adjuvant chemo, and after 6 months, without any chemotherapy, without any recurrence, the patient were randomized to continue this surveillance or randomized to a proactive and aggressive treatment. It was a second-look surgery and HYPEC. But unfortunately, this proactive treatment was no benefit for the disease-free survival on this patient, and also for the peritoneal recurrence-free survival. One thing very important on this trial was the major postoperative complication occurred in 40% of the patients treated by this proactive treatment. This is very important when we are talking about prophylactic treatment. Some comment about prophylactic is that 65% of the patients had a stage 4 on the moment of the primary surgery, have metastasis in ovarian, or have a peritoneal nodule around the primary tumor. That 3 different protocol HYPEC were used. The most was oxaliplatin during 30 minutes. The population were not balanced by the mutational status, and the severe morbidity could not be acceptable in the setting of a prophylactic treatment. Another trial that has been very similar to HYPEC T4 is the COLOPEC, is the Dutch trial. This trial was enrolled approximately 200 patients. The patient have T4 or perforated tumor, and the patient were randomized to adjuvant systemic chemo and surveillance, or allocated for adjuvant HYPEC. On this patient, on the global experimental patient, only 8 patients received simultaneous HYPEC. The others, the patient received HYPEC at 5 or 8 weeks after the surgery. It was a staged HYPEC for this patient. The primary endpoint was the peritoneal recurrence survival, and at 18 months, the investigator did a laparoscopic test for this patient in order to find peritoneal relapse for this patient, but only 65% of the entire cohort received this diagnostic laparoscopy. The primary endpoint was peritoneal metastasis-free survival. They did not achieve significant for this proactive treatment, for the use of staged HYPEC with oxaliplatin. However, the morbidity was very low for this prophylactic treatment. Some comment about COLOPEC, that the primary endpoint was negative, but some patients received up to 3 surgical procedures. Surgical procedure is an aggressive procedure for a patient without evidence of disease. We have to balance how to use the surgical procedure when you don't have any disease for this patient. But however, for 3 surgical procedures, the morbidity was acceptable on this patient. Also, they used the laparoscopy at 18 months and only added 9 patients with peritoneal carcinomatosis. The question is, it is needed? Well, we don't know, but I think that the ColoPEC-2 will give some answer about this question. But one advantage for this trial is that an staged hypet could allow to refer a patient from the non-hypec center to hypec center to do hypec. Could be an advantage for this trial. And then we arrived to HypecT4. The objective for HypecT4 is to evaluate the safety and efficacy of the cytoreductive surgery and hypec using mitomycin C in locally advanced colon carcinoma. The primary endpoint was the local regional control disease at 3 years, and secondary endpoint was disease-free survival and overall survival and the safety. It was open label, it was multi-center randomized phase 3. The sample size was 180 patients, and the center included was 17. This was the flowchart of the trial. The patient included and randomized for logistic reason. We had to randomize the patient before the surgery, and the randomized patient included patient was patient with clinical T4 by imaging test, and also the N0 to 2 and was allowed if we are going to remove the lymphatic disease during the surgery, but metastasis was not allowed in our trial. Then the modified intention to treat population was 184 patients, and it was randomized to surgery and surgery plus hypec with mitomycin C 50 milligrams per square meter during 60 minutes. This is the recruitment, and these were the results for this trial. This is a very huge table, but the idea for this table is that the both groups were balanced in all the high-risk factors to develop the metachronous peritoneal metastasis. You can see that the allocation, the state, end state, the grade of differentiation, the mutational status was similar between the 2 groups. Also, you can see that the quality of the surgery was very similar between 2 groups. You can see here that the mean of the lymph node isolated of the use of the laparoscopic approach was similar between 2 groups, and there was no any difference. The primary endpoint was the local regional control rate was better on the patient that received hyper than the control group with a hazard ratio of 0.21. Also, if we can see here that this is the pattern of the relapse for this patient, you can see that it was very statistically significant that the control group have more peritoneal, more local regional relapse than the hyper group. On the forest plot analysis, we can see that a specific subgroup of the patient of the PT4 definitive pathological T4 colon cancer have more benefit with the use of hyper than the entire cohort. In this subgroup of the patient, we can see here that the local regional control rate was better with the use of hyper than the control group. This analysis have been not published on the paper. That is the disease-free survival in this exploratory analysis of this subgroup population, the PT4 colon cancer. You can see here that the disease-free survival, the curve are separated during the follow-up. Maybe more follow-up or the definitive follow-up or analysis will give some answer about what happened with this specific subgroup of the patient. The disease-free survival was better in the hyper group, was not statistically different, and also the overall survival. As I referred before, I talked before a lot about morbidity in the prophylactic setting. You can see here that the use of hypec did not increase the toxicity or did not increase the morbidity in the experimental group. The use of hypec don't increase any morbidity for this patient. Also, I will do a critical about our study. I think that I know the Hyperthermic. I can criticize the Hyperthermic also. And we are going to criticize or discuss about the primary endpoint, the overtreated population, the large confidence interval in the hazard ratio result, and the laparoscopic approach is low. Maybe this point are I think that they are the weakness of this trial. The primary endpoint, why we have chose the local regional control rate. This is a very controversial question. Well, local regional control rate is used surrogated endpoint in a lot of trials. A local regional control rate requires less sample size and less time of the follow-up to achieve the result. And then the consequence is that the trial is cheaper for us. You remember that this is an academic trial. It is the funds are very important in order to complete the trial. And this surrogate endpoint, it is useful for this endpoint. The trial was designed to achieve different in local regional control disease. The trial was not designed to find different in the disease-free survival or overall survival. We don't expect to achieve different on disease-free survival, overall survival, but we can achieve in long-term follow-up. But it is not the objective of the trial. Also, we are testing a local regional therapy. It is very important because the effect of the hyper is a local regional effect. And then we thought that the best endpoint to define what is the utility of the hyper was a local regional control rate or peritoneal control rate. It is very common when you read the radiotherapy trials. The radiotherapy trial, the most used endpoint is the local regional control rate for the radiotherapy trial. Also published in very, very high level journal, and also incorporated to clinical practice. Disease-free survival, we have seen that disease-free survival, for example, in PT4 gets a benefit on with the use of hyper. More longer follow-up could give us some response about that. The other point is what's happened with the overtreated population. Okay. We know that most of the prophylactic or preventive treatment assume a population that will be overtreated. This is assumed by the prophylactic measure. But we should balance the overtreatment according for the benefit that we obtain. In this trial, we have seen that the morbidity added by the hyper is almost null. There is no more morbidity with the use of hyper. And also from the Foxtrot or Hyperthermic, we can see that approximately 25% of the patients will be overestimated in the preoperative imaging test. We have to improve the accuracy for the imaging test before to decide any treatment. For statistically criticized for the trial is that the primary endpoint has a statistically significant, but the confidence interval is so wide. This is because the low number of events that we have on the trial. Then we performed a restricted mean survival time method in order to assure the finding with a statistically significant in 24-month cutoff or 36-month cutoff. You can see here that in both cutoff we obtained the statistically significant. And also the laparoscopic approach rate is low. It had been criticized for the trial. Well, I agree with this criticized because the most of the center included on the Hyperthermic was traditionally surgical oncology center with a no minimally invasive approach is used on this center, but the approach was similar between group, and the hyper did not have a negative influence on it. Both groups were balanced according to this approach, and also the laparoscopic in T4 is still under debate, and it has not been worldwide accepted. I think that this is the best approach for the T4 colon cancer, but we know that this approach has not been spread worldwide still. In conclusion, for the end, the use of HIPET, we can see it associated with a very good surgery in locally advanced colorectal cancer, improve the local regional control rate without increasing morbidity. And this clinical benefit could be greatest for the definitive PT4 subpopulation. Thank you so much.
Thank you very much, Alvaro. Great presentation. So not only it's a great presentation, but also we already have questions. So here is the first question coming from Stefano Magnone. Is it better to wait for the PTM and proceed to HIPEC after adjuvant therapy, or do you rely on clinical stage and proceed to HIPEC at the same time of the resection? So of course you can tell us about your trial, and you can tell us what you think about larger use of this strategy.
Yeah, this is a very good question. We do this question, but I think that we have some benefit. We have some disadvantage with each approach. As Colopec trial, this is a staged HIPEC. It allows you to select the patient according to a pathological state and not overtreated patient. Yeah, this is a good strategy. The disadvantage is that you are operating the patient for a second time. How do you explain to the patient that the patient had to receive another operation? Maybe the adjuvant therapy could be delayed, or maybe you can obtain some morbidity for this patient. We have to investigate about this. I have no clear idea about that. What is better? I think that the simultaneous HIPET is better, but the disadvantage is the overtreatment. Well, but after this trial, you can see that there is no added morbidity for this group. I don't know. I don't have the right answer for that.
Nice. Also, Alvaro, I can add a comment about the hypothesis of the HIPEC. We have the collagen that is going to be formed after, and this theory that Paul Sugar-Baker always say about the entrapment thesis, we lost the benefit when you use a HIPEC after 72 or some weeks after the treatment. So this is not proven. We don't have this data to embase our condition, but we have to learn that you have to think about this using this information to indicate HIPEC after the procedure. So
yeah, this is a very good point.
Yeah.
The entraped cells, yeah, the entraped cells. Yeah, this is a good point in order for the disadvantage of the staged HIPEC. Yeah, but it is theory.
Just before we move to the next question, we would like to ask the audience a question, and Maria is going to run a poll. And if you could please answer this question, just to understand, how do you think about prophylactic HIPEC in your institution? We have here surgeons and people that are training or are already performing HIPEC. So if you could please answer this, and while you are going to answer, we can move for the next question.
We cannot vote.
No, we cannot vote.
Okay.
But I ask you, are you performing outside the experimental?
Yeah. We are performing. Daily practice, we are performing.
You
Also,
need to
we are,
stay true to yourself.
yeah. So we are registering all the patient included because we want to do a real life after Hyper T4. What happened with this patient? Our feeling is good for the patient. There is no added morbidity but for the result we have to wait. But the morbidity is very acceptable for this patient.
And how do you suggest to improve the selection of the right patient that is the T4, and also how to reduce the overtreatment? What you're feeling during the practical daily experience?
Well, do you have result?
Yeah, the results are also available.
Okay.
Yes.
But for improving that, I think that about the radiologists have to improve and to practice about the T4. We discussing in Bruges, as I told you before. We discussing on the multidisciplinary group. We discussing with the radiologist that it is very difficult to different that. Our overestimated rate was 33%, but it was so high because we don't consider the patient with high risk T3 patient into the trial. Then, if we consider the high risk T3 patient into the trial, our over treatment will be very low. This is that the Foxtrot trial include the T3 high risk patient for that, and then I think that the overestimation could be reduced for that.
Okay.
Thank you very much. And one
Yes,
more
you
question.
can go. You can move on.
Yeah, so I was wondering, you were discussing T4 and laparoscopic T4, and indeed there are articles saying that the outcomes are the same. There are teams there are reluctant results that are reluctant. What do you think is the impact of the learning curve or the expertise into that? So would you, for instance, advise for the use of laparoscopic I don't know, laparoscopic treatment from a certain threshold and propose rather an open treatment from a different sort of ear volume? Or
well, this is a good question, very good question. I think that you need to have the learning curve for the laparoscopic approach for advanced tumor. It is obvious, but I think that the most of the colorectal surgeons have the skill to remove T4 colon cancer. Maybe multivisceral resection or pelvic exenteration could need more expertise for that. But I think that the more of the colorectal hospital with a high volume have experience to do that. And the other question is to have expertise to do the HIPEC during this procedure. I think that the learning curve to incorporate the HIPEC to colorectal surgery is not so difficult. This learning curve, it is only a chemo protocol. You have not to decide which protocol will be used. It is only for T4 colon cancer, and also the introducing of the cannula through the trocar. I think that only with 2 or 3 procedures that you see, you can do that. I think that it is not so difficult for expertise colorectal surgeon. I think that they could do it.
how about the anesthesia teams and the light professionals?
Well, I think that it is totally different. I think that the prophylactic setting for hyperperitoneal carcinomatosis with HIPEC. I think that the HIPEC in a patient with only the surgery from a colon don't provoke too much instability or too much dynamic alteration for the patient. I think that a learning curve is necessary, but I think that it's not too difficult to learn it.
Very nice. Very nice. Thank you, Alvaro. I will read another question from the audience, and it's from Vivekant Sharma. I don't know if I spoke well, but the question is, I remember you mentioning earlier doing the collab with the Foxtrot group, they find the best way forward to locally advanced colorectal cancer. Which endpoint would you like to consider when you do that? Again, congratulations on the Hyperthermic and your recent publication.
Okay, thank you so much, Vivekanand, for this question. That is, I think that the endpoint has to be disease-free survival for when you combine the systemic chemo, the disease-free survival is the best endpoint for that, not the local regional disease. Also, the hyper will avoid the local regional disease, and maybe the disease-free survival will improve with that. But I think that the endpoint, when you consider the systemic chemo, the best endpoint is the disease-free survival, not the overall survival, because the overall survival have too many factors. After the relapse, have the surgeries, different chemo, immunotherapy, but the disease-free survival is I think it's a very good endpoint for that.
Thank you very much. And so just to make it clear, we have a question from Ara Semre Kanda. So she's asking, what is your adjuvant therapy strategy for a patient who underwent surgery and prophylactic hypomycin C for PT and zero tumor? Do they need any adjuvant chemotherapy? Very important point, I think.
Yeah, according to the guideline, the PT4 with N0 and 0 receive adjuvant chemo. In our trial, this type of patient, this subgroup of patient, receive a FOLFOX or CAPOX during 6 months.
So thank you very much, because this underlines one thing. So once again, and it goes like in the same direction as the endpoint, HyPreg protects from local regional recurrence, but does not, of course, protect against systemic recurrence. So for what we know so far, we might need both, right? Unless we consider that in some special, I don't know, histological subtypes, there is one risk that's more developed than the other.
I agree. Another question is
what is the role of frozen section in the T staging? So once again, we are in the perioperative situation.
Yeah, it was a question that we did ourselves during the protocol setting of the Hyperthermic. If we consider the frozen section to include the patient. There is a very, very high problem with that, because it is very difficult for the pathologists to define the T4 colon cancer. It is very difficult, and they talk about that in the meeting that we have in Bruges, that the pathology is very complicated to define what is the T4, T4A, T4B, but the most difficult is to differentiate the T3 high read or T4A. It is very difficult for them. They say that in a frozen section, it is almost impossible to differentiate it, this little line between the two stages, in order to include the patient for that. This is the reason that we don't use the frozen section.
Okay, thanks, Alvaro. We have another question. I think that we already answered this. We have two questions. It's an anonymous question. What about T4 rectal? As this study shows reduction in both distant and peritoneal mets?
Well, on this trial, we did not include the rectal cancer. This trial did not interfere with the neoadjuvant indication for rectal cancer. We only include patients with superior rectal cancer above the peritoneal reflection that they were not considered for neoadjuvant therapy. These are the patients that were included with some rectal cancer, but not extraperitoneal rectal cancer was not included on this trial.
And it's worth saying that the risk of peritoneal mets for patients that are under that localization is really reduced by half. So it's probably 10% for rectal cancer, while it's 25% about for colorectal cancer. And we have so many other things that are added to in the protocol. So that's maybe something to design separately, but it's interesting. It's an interesting lane for the future, maybe.
Yeah, maybe for the future, but I think that it will be very complicated. I think because there are a lot of strategies for rectal cancer. Then to perform a trial protocol with associating HIPEC with neoadjuvant, which neoadjuvant is rapido scan or TMT scan, or I think that there are so many variables to set a protocol for this disease. I think that it could be
so
very,
probably
very,
more in the
very,
curative setting than in the when
Maybe.
there are peritoneal mets than in the risk setting.
maybe yes.
Alvaro, I have a question for you. We saw at the profellowship that a high incidence of peritoneal mets that were not visible at the images TC or MRI. And your work, you use it as a pre of relapse that was out of imaging of peritoneal relapse and also tumor markers and anything. Do you thought about this? Some missed information on the images before considering that the patients to be free of disease?
Yeah, of course. But well, the problem is that the peritoneal carcinomatosis, early peritoneal carcinomatosis, as you see on the ColoPEC, have a high point on the 18 month approximately. Is a very important point during the follow-up of the patient. In our trial, the follow-up is 36 months. It means that almost the most of the peritoneal relapse happened during the 18 months. Maybe it could be invisible in a CT scan or PET scan. But if you wait on the follow-up, I think that this peritoneal relapse will be seen by this proof. Also, the follow-up and the imaging test are the same in the both arms. I think that some of the patients has peritoneal relapse, and we did not discover them. I think that because on the follow-up they develop this peritoneal relapse. We are doing the final analysis of the trial with the last patient follow-up. I think that some response about that I will give you in other report for the trial, because this report was median of the follow-up. We obtained the median of the follow-up the 36 months, but not all the cohort achieved the 36 months of the follow-up. Maybe we have some answer about this question about the total peritoneal relapse, also for disease-free survival and also for overall survival could be very, very important. I promise this year we are going to have some result about that.
Okay, and
We're
how are
looking
you
forward to it. Yeah.
Mhm.
And Alvaro, thank you. But how are you managing the relapses?
Yeah, but it is very variable. All the relapses were presented on the MDT committee, and the peritoneal relapses, the most of them were managed by systemic chemo and by cytoreductive surgery again. But the systemic chemo was managed as hepatic metastasis or lung metastasis in the same protocol that we use usually. The best is that the patient that we use the laparoscopic approach, the peritoneal relapse is easier to manage by surgical approach than the patient managed by open approach. We have seen, we have this feeling for that.
Okay.
So we have a question from Diego Zambrano. So how do you approach the patients for the indication of prophylactic HIPEC need? Which recruitment barriers did you encounter? And this is, I think, a very interesting real-life question, because sometimes colorectal centers, which we normally see those patients, are different from peritoneal centers. How do you organize that care in Spain?
Yeah, the recruitment at the beginning was very slow for that, and it is complicated to find T4 clinical T4 colon cancer in the CT scan. It is difficult because the most of the clinical T4 colon cancer are operated by obstruction, is operated by perforation, but for scheduled surgery for clinical T4 is not so frequent. And that this is a very difficult. It is different than FOXOS trial, for example. You have the T3 high risk. I think that if you have the T3 high risk and clinical T4, the recruitment will be faster for that. But only T4, the recruitment was difficult for this trial. The next trial we are setting up is including the T3 high risk for that.
So before we go any further with some more very concrete question, I was wondering about your next protocol. So we have HIPEC T4, we have Foxtrot out there. So how should future research in this field look like? What would you place your bet on as a future strategy for these patients?
Yeah, I think that the best strategy is a combination for the both. I think that the best strategy is neoadjuvant for the patient, and after HIPEC for this patient. I think that it could achieve a very high rate of the patient with we obtaining a cure for this patient. I think because also the regression rate of the use of neoadjuvant chemo is very important. So if you read the FOXOS trial, the regression rate is high on this patient. I think it is very important for that.
Thank you. And Enrique Boldor is asking, any news about when the HIPEC will be included in guidelines for T4 colorectal cancer?
Well, the guideline.
Did you put it on your Christmas list?
Yes.
The guidelines are managed by the oncologists. We have to combine the oncologists to do that. We are trying to combine. We are going to do the final analysis of this trial. We hope to get some important result for that. And also we are working also with Colopec author, with Peter, and also to do a combination of the HIPEC-T4 Colopec analysis in order to see some question for that, in order to which patient will be benefit for the HIPEC, which subpopulation of the patient will be benefited for the HIPEC. I think that if we select a restricted subpopulation for that with higher benefit of HIPEC, it could be included on the guidelines.
Thank you very much. And now let's get back to preoperative with Siva Gavini asking, in perforated tumors, do we have an increased risk of intraperitoneal infections? And is the postoperative antibiotic protocol same in both arms? Can you please tell us your protocol?
Well, in perforated tumor that were included in our trial, perforated was a tumor with an abscess, and it was drained by percutaneous way. And after that, the patient were studied, and the patient were included in a schedule, surgery. We don't use the hyper for emergency, and we don't use the patient for peritonitis, only for this patient. And the perforated tumor was similar between the both group, and the antibiotic was hospital protocol was based on the we use overall high spectrum antibiotic for the both group.
Okay. There is a question from Eras Emre. Do you have a patient incidentally detected peritoneal carcinomatosis during surgery for T4 tumor in the study population, about 200 patients?
Yes, I put on the flowchart of the trial. We have to randomize it. This is a weakness of this trial because the intention to treat population was a modified intention to treat population. We exclude from the analysis, we exclude the patient with peritoneal carcinomatosis. We have found, I remember, we have found approximately 6 patients with peritoneal carcinomatosis during the surgery. This patient was excluded from the trial, and the patient was treated according with the finding.
There is some data from the US showing the role of circulating tumoral DNA in predicting recurrence in patients with appendiceal and colorectal peritoneal mets. Do you think there would be any role for that in prophylactic setting?
Absolutely. I think that the ctDNA, this is the next tool that we will have to select the patient for all the management. In the trial that we are setting up about the neoadjuvant or hyper, we have included the ctDNA in the study because it is essential, because after dynamic trial you can see that the adjuvant chemo could be avoided in some patients without this ctDNA. But we have to be cautious about the ctDNA because there is a lot of methodology to find it, and something a negative result could be a bad analysis performed and not a real negative test. We have to be cautious with that. We have to analyze this to have several trials again in order to incorporate for the clinical practice. But I think that on the future will be a very, very important tool in order for the scheme of the treatment for the patient, to give to different arm of the treatment.
Yeah, I read a paper about ctDNA also on the peritoneal lavage before surgery, and they are comparing serum ctDNA with if there is not a ctDNA or no in the ascites or in the lavage, and also after, and some weeks collected after the ctDNA. It's very nice. I think that ctDNA is going to rule some of our indications of adjuvant, and also about using or not adjuvant treatments.
Yeah,
Very nice.
there are a lot of research line about the ctDNA that we are conducted a line on the ctDNA research also in isodermic soma peritoneal. that it is very important on the ascites, on the liquid, abdominal liquid or peritoneal liquid, that we can detect the ctDNA, but also we cannot detect the ctDNA on blood. And we say what's happened, and also there's an important study that look at the ctDNA is negative, but in the peritoneal relapse. You have peritoneal relapse and the ctDNA, the circulating, is negative. It is totally different than hepatic metastasis or lung metastasis. The hepatogenous metastasis, it is totally different. But peritoneal relapse, the negative result for the ctDNA is so frequently. I think that there is a lot of line for research for that. It is very, very interesting. Also, which mutation you will detect. We are going to use for our setting trial. We are going to use commercialized test with, but the cost is so high for each patient. I think that today it is very difficult to incorporate for a daily practice for all the patients with colon cancer to assume 1,500 euro per this test. I think.
And we don't say it enough, probably, that this is a major obstacle in our surgical trials everywhere in the world. We don't have the drugs, so it's very, very difficult to find the financing to build those surgical trials.
Yeah,
so
of course.
That's another great merit for your HyperT4.
Well, also for HyperT4, but we are expecting fund for the next trial, and the fund are so high because we have incorporated the ctDNA, and it is crazy, man. It is very expensive. But I think that is necessary. ctDNA today, this is necessary in order to design the trial. It is totally necessary.
Okay, very nice. Thank you very much, Alvaro. We are moving for the end of our webinar. I would like to thank you, your time, and also to thank Olivia to co-chair this session with me. And I will open for the final words from you both.
Okay, Olivia.
Yeah, so thank you, Artur, and thank you, Alvaro. It's great to have this dynamic to question our own ideas and to stand up creating trials and doing all the work all the way down. So really big applause for that effort, and looking forward to see what the future is going to bring us.
Okay, I only say that thank you for this opportunity to share our idea, our comment. I think that it is very, very useful and very interesting to discuss a paper and to destroy and to see what is the details of the paper. I think that it is fantastic for discussion. I think. Thank you so much for your election.
Thank you. Thank you, everyone. Thank you, Maria, for preparing everything for us. And see you on the next sessions, and see you on the next Congress.